So it's a real pleasure to introduce our speakers for today. So Professor Joe Rafferty is Chief Executive of Merseycare NHS Foundation Trust in Liverpool, and the trust is now one of the largest specialised integrated care providers in the NHS and includes inpatient and community mental health, community physical health, and learning disability and addiction services. And Joe is joined by Amanda Oates. Amanda is an NHS Director of Human Resources and Organisational Development in the Northwest. And she has extensive experience, including director level posts in a number of NHS trusts. And she has operated at the most senior board level since 2008. So Joe and Amanda, you're joining us from Liverpool today. It's a real pleasure to welcome you.
Thanks very much, John.
Great. Do you want to? I'm going to let you take over and you can ask Stephen to move the slides on.
Brilliant, John. Thank you very much, and thank you very much for the invite to speak today. John, if you could just go to the next slide. What I want to do in the next little bit before Amanda gets really into the bones of some of our work is talk about our journey really from us having a probably by default a fairly retributive culture in our organization to beginning to build the stable foundations for a restorative just culture. I mean, you'll hear us talk about lots of stuff today. We by no means have all the answers. We haven't done everything. We talk about a set of practices, and that's exactly what we're doing. We're working out by practice every day what works and what doesn't. And I think if we could just go to the next slide, it's probably useful to tell you just a little bit over the next few introductory slides about Merseycare and the sorts of approaches we were taking to improvement, to safety, to thinking about a strategic future for the organisation, which I think sort of by default left us thinking about the need for to build a set of restorative practices. This slide just is a summary of the organisation. We have about 11.3 thousand staff. We have host a range of services. We have one of the 3 high secure hospitals, mental health hospitals in the NHS. And at the other end, if you look directly below on the left-hand side, we have diversified ourselves into sort of preclinical and post-clinical activities in what we call life rooms, which are a hugely successful sort of set of social prescribing hubs now. We're very dynamic as an organisation. I keep looking at this slide and the numbers change. So I think our latest turnover is more like £720 million. We relate to a complex range of local authorities, where in fact we encounter some of the most complex health inequalities in Western Europe. And I suppose one of the reasons for showing the slide is to show that we are a complicated organisation with lots of complicated service users, that we carry very high levels of risk in our organisation every day. Yet quite a lot of the stuff that we've done, people often sort of talk about how context specific is it, but I mean, I'd argue we're like many organisations in healthcare. We're big and we're complicated and we're dynamic, and lots of things happen that we have to manage in the heat of the moment. So I suppose the slide is about saying, you know, we're not a small niche organisation in which it's relatively easy to do things. We work out of 170 different sites across Merseyside. It's a complicated organisation. Next slide, please. But we've done lots of things that I think many other organisations have been challenged at. We have grown very substantially since around 2015, and we have continued to be busier and busier, with increasingly improving staff satisfaction as we've grown. So if you think about the improvements we've made as summarized in this little graphic, we've done an awful lot of this since 2015, which was the time we started our restorative just culture piece. So we'd argue and will argue that having implemented restorative just culture has been part of our journey towards a sort of growing, more resilient, more successful organization. Next slide, please, which is a very busy one. And I just want to direct you towards the right-hand side of that, striving for perfect care. We way back in about 2014 or so decided that we wanted to be fairly challenging around the ambitions we set for the organization. We borrowed a lot from Crossing the Quality Chasm by IHI and started to talk about striving for perfect care and described this through a set of zero-based goals for ourselves, most of which would fall in the sort of really audacious goal territory. Interestingly, we never set targets for zero. We actually only ever talked about zero as a rightful ambition, but some of that has been incredibly challenging stuff. Zero suicide for people in our care, zero harm for medication, and most recently, on the subject of what we're doing in our time out today is to talk about zero acceptance of racism. So really challenging stuff that demands really, I think, a very strong sense of psychological safety inside the organization. But when we talked about these back in 2015, and we'd spent a long time building our infrastructure around this, strategy, goals, values, as you can see, improvement methodology, leadership campaigns, all of these things. It was our staff side chair who very disarmingly said one day to, I think, Amanda and I, it's really interesting, all the zero stuff, but how about zero blame? And it was one of those moments when it was like a yikes moment. We were caught absolutely in the headlights. And I'm going to hand over to Amanda now, who really thought that we should tackle this question by not having zero blame, which we think is probably as destructive as full fat blame in that sense, but that we needed to think about a mechanism that was going to break open this whole issue and get us to a different place. So next slide, please.
Thanks, Joe. So I think the definition we looked at for just culture was a definition that Sydney Decker wrote, Professor Sydney Decker, and I know there's some links being shared in the chat box. And I looked at lots of literature and different academics, but the difference with Sydney's work was around the restorative piece. A lot of people look at just culture as an algorithm approach, taking people through an incident decision tree approach, but Sydney looks at it restoratively as how can you restore relationships. Now, I think it's important that what we're looking at is a holistic issue. So when something doesn't go to plan or as expected, and I'm deliberately not using the word mistake, that we take a holistic view, because it's not as easy to say somebody's right, therefore somebody's wrong. So I think we need to take that step back and look at it holistically. Next slide, please. And organisationally, at that organisational level, next slide, please, Stephen, sorry. It's my Scouse accent, I speak so quick. When we look at it organisationally, is we need to ask ourselves, why is that culture important? I'm just seeing if the slides are moving on for everybody. It's stuck on mine. Is it moving on for others?
Can you just move it forward there, Stephen? I think it's on the just culture.
Yeah, that's it. Perfect. Thank you. Okay. So why does it matter? Because it matters for our staff, that they feel safe to tell you their views and to give you feedback. It matters to connect with the organisation and the people that we're there to look after. We're in obviously the care business, but actually it also is really fundamental to the people who use your services, who experience your services and have that customer or client interface, because how your people feel and react and behave has a direct impact on their experience and how they flow through your system or use your system. Next slide, please. So I think, what Joe talked about, we asked our staff a very interesting question when our staff side colleague talked about, do we have a blame culture? We asked our staff very, very simply in a room full of clinicians, what was the biggest impact on them trying to achieve our perfect goal of ambitions. And quite surprisingly to us, they came back with fear of the consequences. So the biggest fear they had in implementing our clinical strategy about aspiring to achieve perfect care goals for our patients and our service users was the fact that they felt the fear of taking those decisions and risks, because they felt if it didn't go to plan, or wrong, if you like, in old language, that they would be blamed and shamed. And at worst, there'd be serious consequences for their professional status, for their employment, and it would lead to lots of damage and retributional action. Next slide, please. So really, from those conversations, our restorative just and learning culture was born, because staff wanted to feel they could work in a safe place that's not just physical but psychological safety, and be treated fairly and compassionately. Next slide, please. Now, I'm not going to go into all the detail on this because you've got the slide deck, but you know that age-old saying is, a culture eats strategy for breakfast. And that is really what the slide's trying to depict. There's a lot going on that's often nebulous in concept, but if your strategy is incongruent with how your staff feel on the ground, then mistakes and concerns are often not raised. By best, they're either bypassed or ignored because people aren't taking personal or professional accountability. So it's not about being blame-free or anything goes. It's about a careful balance of fairness, accountability, and learning. Also, restorative just culture does distinguish between causation and contribution, and that's really important. Rather than saying Amanda caused X, it may be that Amanda contributed to X, and there may be other contributory factors. And it also distinguishes, and very much did for our organisation, the work that happens on the ground versus the work that we imagine people to do. Sometimes at the top of an organisation, we might have an ideology that they follow all the policies and procedures that we have, and they operationalise them to the letter. But actually, people find a way of bypassing that if it's not user-friendly or it's not clearly understood. And the other important thing was actually trying to reduce hindsight bias. So rather than looking backwards all the time and saying, with the benefit of hindsight, when you know the context and the outcome, I wouldn't have done that. I would have done this way. Well, why did Amanda or Joe do it that way? We're actually being more forward thinking in our outlook. And we talk about a lot in Merseycare about what and how, because who will always really beat a good person if you focus on the who, and it becomes very, very personalised and you don't tend to understand the granular level of details and the context of which something occurred. Next slide, please. Now, a lot of the work, people may recognise the work on organisational health, which is McKinsey's work. And I think somewhat surprisingly, what we found through significant change, significant organisational acquisition, was that at the same time as focusing on our organisation's health, so the health and well-being of our people, that had an actual impact on the performance of our organisation through large-scale change, through various acquisitions, and even during a pandemic. So what we found, not planned initially, but what we found is the direct correlation between organisational health and performance. And to the right of the slide, there's some just data in terms of showing what that means in our performance metrics as a trust. Next slide, please. So I wanted to give you some tips, if you like, some of the things that have come to us through our journey. And there's a lot more we could give on this, but we've got limited time to speak. I think the first thing is to acknowledge, a lot of people say to me, Amanda, have you always done things right in Merseycare and all things done right now? Of course, we recognise the hurt and harm that colleagues have experienced in the past through our systems and processes that have affected their health. And actually still today, there's corners of Merseycare that would say, we don't recognise a restorative just culture. And Joe touched on that. We're talking about anti-racism and racism and systemic racism within the organisation today. But some of our key lessons are around building psychological safety at an individual and a team level. And one of the lessons we've really found true is the language around mistakes and error. And if you actually demonize the language, it actually affects the conversation. So it's something we really wanted to talk about, which is why we tend to talk about when things didn't go as planned or as expected, versus Amanda, why did you make that mistake? Because it changes the safety and it changes the conversation. Next slide. And the other one is around having a framework. We've worked extensively over the last 4 years to develop a framework to try and reduce the bias, to ask and look at trigger points, to go through gateways, but also really importantly, to think about the psychological harm and think about how it can be restored. Of course, the key message here is you don't have to fix something or restore something if it wasn't broken. So you must think in that prevention space. So try and prevent an incident occurring by looking after your people, supporting your people, that they feel safe to raise those concerns, rather than dealing with the aftermath. But we have a process and a framework if there is an aftermath. Next slide, please. And this is the bit I talked about before, the difference between the design and the experience. And for us, the closer you make that alignment, the better the patient safety dividend. In other people's terms, it may be a dividend in terms of performance, or a dividend in terms of financial, accuracy or savings. Next slide, please. And again, this is the point I made before between about causality versus contribution. So if you think about the language that you ask, if you're looking at making a direct causal link, is who's responsible? What we're going to do to that person? Let's go down the rules and see what that person broke, and what are we going to now take in terms of disciplinary investigation, safety reviews, external regulation, and that may mean legal sanction. Versus when you ask the question, what? There's a number of those things in the middle of the slide deck there. You start to think about, does the person feel safe to give feedback in that moment, in the context that that incident or event occurred? If they feel safe, they're going to be more candorous, if you like, more truthful in their reflections and their giving about what occurred, because they feel safe to do so. They're not going to be blamed, they're going to be heard, and we're going to be curious and sort of inclusive in those reflections, and it gives a more safer debrief. And the important thing is what do you learn from that debrief to prevent similar things reoccurring time and time again? So it builds a foundation for real transparency and learning, both at a team level and an organizational level. The next slide, please. And this is really important, that too often in organizations' life, we spend all our time talking about the unwanted outcomes, and we say, what went wrong? Why did that happen? And all we talk about is, if you like, the things that not really very nice to talk about. Whereas there's so many things that go right. And what Sydney's research is, you need to balance the unwanted outcomes with looking and experiencing and discussing the majority of positive surprises that exist within our organization's being, and understand why that was successful, what things happened, because that can help you with your prevention agenda, but it can also help you accelerate that at scale and pace. Next slide, please. And this is something I'm often asked about. Amanda, if you were starting your journey again, what would you do differently? We have a lot of organisational values, and Merseycare, they're surrounded by the word CARES, but we did a real deep dive into the value of respect, and we really described what that meant and the impact of incivility and disrespect on people's cognitive ability to function, often called as the soft and fluffy stuff. If people want to look at a great TED Talk, I'd recommend you look at a TED Talk by a gentleman called Dr. Chris Turner, whose this work is built on. But he often talks about, what's your theme tune? When you walk in the room, or they hear you walking down the corridor, what theme tune is going on in somebody's head? You certainly don't want it to be yours. What do they think about when they know you're coming or they hear your name? And I think it's really important for us to reflect on that whole civility and respect conversation. Another good reflection is when, your children, our children will know your boss's name. So my kids know Joe's name. They know who he is. And what do your children think about when they hear you talk about your boss's name? So that's just something for us to reflect on. So that's the civility and respect coming to bear, and how you talk about things at home actually is a reflection of what's going on within your organizational health and your organizational culture and environment. Next slide, please. I'm going to hand over back to you. Oh, I'll do this one. So I think my last slide before I give back to Joe is there's some metrics in terms of our staff survey data there and our disciplinary data. So what we can see by that is we see there's lots of informal conversations, but very low level of disciplinary investigations in terms of looking at incidents and events through a blame lens. But of course there is some, because there's just culture also means accountability. The other bit that the data is showing is even during the pandemic, we've sustained our staff satisfaction levels. But really importantly to us is staff feel safe to tell us when things aren't going to plan or expected, particularly around a culture of patient safety. Feeling able to speak up and raise concerns is absolutely paramount to that organisation moving and that organisation's health. Over to you, Joe.
Thanks very much, Amanda. Just one thing I'll add to that last slide is the reduction in suspensions of 92% and disciplinaries of 80 or whatever. Yeah, 89 and 91% took place from 2015, and from 2015 to today, this organisation's trebled in size. So for me, it's a sort of indicator that I'm not going to say like we've got psychological safety perfect, but we have created an environment in which it's really possible for this organization to engage in large scale change and at the same time maintain a really strong positive relationship with staff. The other thing I'd say is it's really critical to choose something that will show demonstrable progress if and when you start this work. I mean, I often tell the story. Our staff side chair said that it felt a little bit like chief executive BS. I can let you work out what BS is yourself. But that they would 100% believe this if they could see a change and a good directional change in sort of staff relations figure. So it was really important to grow credibility around this. That what we were doing was moving from a set of principles, which have been well articulated by Sidney Dacker and others. But I think the step that we made here was to create a sensible, tangible set of practices around this. And the data shown particularly here is really important for that. We'll go to the next one then. There are really, really wide-ranging benefits from this. I mean, we could talk forever on this slide. I'll not go through it all. But to say that, we have, in terms of the trust, really understood that we operated in a space where we had policies that created harm, and the need to move to a more relational system through our HR colleagues, where we introduced healing processes. And, we were not an organization, and Amanda's certainly not a director of HR who set out to harm people, but Amanda referenced this point about work as done versus work as imagined. And we often assume when we set up very good systems that the workarounds that take place, that workarounds don't take place and that everything works as we imagine it would. I mean, what we discovered was there was a big gap between our imagination and the frontline reality. And I think it's taught us for any trust in any organization, in any health system, that the reduction of that gap is a really significant issue to achieve, safety dividends of the type that Dacker talks about. I think too, it's encouraged us to see openness and transparency as an ally. I mean, in health systems is very, very difficult, especially heavily regulated health systems like the type we all work in. The notion that it's difficult for the boss to hear bad news is very prevalent. And I think, in this organization, I get to hear lots of brilliant news as well, by the way. That's the thing about the safety 2 idea, not just safety 1. But it's really important to hear when there are problems in the system. Then for our workforce, I'll just go to the last point here, which is the one about asking what and why instead of who. And I think that has shifted our drive into a much more genuine continuous learning type of cycle. And I think this connects us directly to work that Amanda referenced on organizational performance versus organizational health. I mean, I've grown up in an NHS system where we valued performance rather than organizational health. So I often use the phrase, we put the fire under people's feet. And I think what restorative just culture has done is put the fire back in their belly, which re-engages, in my view, most clinicians with their core vocation, actually. And then lastly, for patients, if I go to the last one again, staff morale is higher as staff are empowered to do the best job they can do and to have a real voice in feeling safe around improvement. And, you know, the point is, happy staff produce better, safer care. So the virtuous circle element of this is really, really pronounced. And I'd argue the vicious circle piece is something that, you know, we're moving away from. Next slide, please. It starts to describe a little bit about, you know, what we see around incidents. One of the things I'll do, John, is we'll redraw these graphs and pull them right back to 2015. Because if you go back to 2015, you see a much bigger change. So the window's a bit narrow here, but you can see in total incidents, we continue to increase the number of total incidents reported. And we've just tipped over for the 2-year period. We've just tipped over the upper confidence limit to show a statistical change now in what we're doing here. And if you go to the next slide, it shows the sort of breakdown of those incidents. And while they look really flat, I think when we do this from 2015, you'll see that it's actually much more about reporting no harm or low harm events and a reduction in the overall reporting of serious incidents, which is pretty much what you'd predict. All the theory would say, and all the extrapolation from other safety systems outside of healthcare would predict that sort of pattern of change. So the last slide then is really in summary. I think in this world, it's really important to focus on concept into practice. I think there's a risk if we stick in the concept phase that staff will get cheesed off and you get to the so what moment. So we and particularly Amanda, this is a great success of Amanda's team, it has been to really take this stuff and make some practical toolkits available. We love the idea that we celebrate great stuff, but it's really important that the boss hears bad news. And I would ask yourselves the question, if you're a leader in a healthcare system, when was the last time you apologized? I see that as it's almost like my little yardstick litmus test on this, because when you hear bad news, you need to be receptive to that and supportive of those people who deliver it to you. And I go back again to say it's really critical that we dissect out the difference between who's accountable for what. I mean, in nearly all of the things that has happened in our organization, the accountable person has been me, because it's the systems that have allowed certain circumstances to be delivered. And last time I looked, I was the accountable officer. Whereas in our old system, we drove accountability and responsibility straight down to the people on the shop floor, you know, and to be able to shift that dynamic is a critical part of creating psychological safety, as well as actually producing higher performing boards, I have to say as well. We co-produced the entire approach with staff side. You know, we argued and fought. I didn't, but Amanda did. But we did that in a constructive way, and we got something that's much better as a result of that. And this thing about moving to learning from routine work has become a real thing now. I think see people as the solution and not the problem. I mean, God, that sounds really, really obvious, but it's remarkable how clouded and hidden that was for us until we started to unearth this. And I think what then happens is you not just get an organization with people who want to engage in continuous improvement, but I would say you then connect, because of the psychological safety bit, you connect people directly to innovation, R&D, and really building not just your short-term benefits, but your longer-term change as well. And again, I think that's the thing that when we talk to particularly our more senior clinicians, that's something that they want to do because that's a real attractor to stay in the profession at a really hard time. And lastly, I suppose, sharing your vulnerabilities. This isn't easy stuff to do, but it's incredibly rewarding, I think, if you allow people to engage in a sort of psychologically safe way. So the last slide is thanks very much for talking to us or allowing us to talk. And there's a great book out there, I feel like I'm, Graham Norton on a chat show now, but here's my book. There it is. So thanks very much, everybody.
Thank you.
Oh, thank you, Joe and Amanda. That was really wonderful. And, I appreciate in the time constraint as well, you packed so much into that, and thank you. I know we're going to have some questions, and I'm going to certainly encourage people to post their questions there. But, I might just start if that's okay. Obviously, our own health service in Ireland has become interested in the concept of just culture and recognizing its importance, I think, from the literature and from work such as your own and the book. But again, I suppose like the idea of work as imagined and work as done, there's just culture as imagined and just culture as done. And why is it so hard to do? It seems like such a good idea. What are the maybe initial things that you have to get over? What are the first steps really if you want to change your organization?
I think I go back. Do you remember the film that you've shared in the clip? We produced a film in 2018 with Sidney Decker, which had depicted our story up to that point. And when that film was shared, which really shared our vulnerability, it shared the hurt and the harm that existed in our organisation and the impact that had on our people. For as many people who said, wow, that was really good, thank you for sharing, a lot of people asked us if we were frightened, what it meant for us, what it meant, did it show us as leaders in a bad light? And that, I think it's that fear that prevents, because you have to take a step back as a leader and do what Joe said. You have to listen. You have to have the courage to listen. You have to have the courage to listen, not to create an action plan, but listen to understand what people are saying and in their context and their environment. And in that listening, then you might have to lean in and say, well, we didn't get things as right as what we thought we had. And we have to admit that fallibility and show our vulnerability and apologize. And I think some people don't want to step forward because they're frightened about what it says about them, what it says about their organization. And it's fear that prevents, due to their own psychological safety,
Sure.
probably.
And how hard is that to do? In our current environment, where there's media focus, where there's political attention, how do you get the cover to do that critical bit of work at the beginning, like you said, opening it up, hearing the stories, saying sorry without derailing the whole endeavor?
It's a really great question, that, John, and I think it's why I would always say to people, you really need to engage senior leadership in this. People who, in a sense, set the weather pattern for an organization. Because I'd always say if they're not buying in, it's really difficult for people on the shop floor to believe that when they make the big shift, somebody above them is, not going to criticize them for it or whatever. So that's one thing. I think having authentic senior leadership buy-in to this is important. I think Amanda's point about being on moving away from the hero leader model and being a little bit more vulnerable to really what happens, to listening and understanding the stories and responding in a very different way. And lastly, and I think this was really critical that we undertook this step, because your point about how does it play in the court of public opinion and political opinion and all of those things, was we were very quickly able, John, to demonstrate benefit as a result of what we're doing. So I think if you're undertaking this in part, it may look and feel like you're exposing a sort of broken core, a rotten heart or whatever. But if what you say is, and I've used the phrase already, if what you say is we're moving from a vicious circle to a restorative, righteous circle, and you can show what we've called safety dividends, and we didn't talk a lot about it today, but we have an evaluation that shows we save millions of pounds by doing this, then suddenly the business case is a very different one, John. So you need to structure the business case in terms of what does it mean for the people who lead it? What does it mean for the people who receive it? And then what does it mean almost for the people who regulate us? And if you can start to make sure that you're touching each of those three areas as we've described, then it's a lot less scary to get into than at first sight it might seem.
And how has your work been received by people like the regulators? You know, have you had good, you know, engagement and feedback?
I'd say when we were first on the journey, people were frightened of what we were doing because they didn't understand it, and it was new in health, really. Definitely experienced in other sectors, but new in health. So I think originally when we started, we were new in that game. But I think by the time we released that video, I think people were more ready to receive it then. I think had we released the film and what we were doing probably 2 years earlier, it might not have been, the environment might not have been as ready. But I think on what Joe said, the evidence and the data we can use to demonstrate the impact that it's having, we can do that not just in our organisation, but other organisations who've used the tools now. So, you know, we do a lot of external training to other health providers and, you know, charity sectors who've used our approaches and frameworks and applied that and got similar traction and evidence. So I think now, you know, we're quoted in all the NHS people plans and other literature now as being, you know, a very strong case study in this, with this field and this piece of work.
I think the other thing, John, is, I mean, it's not like the alternate system really works.
Mm-hmm.
You know, we've had like decades, haven't we, in health systems all over the world where the sort of performance culture type of approach and, you know, grind down towards targets and so on. You can get some marginal gain, of course. You know, we've all done those sorts of things, but in terms of looking for a sustainable solution, it has to involve the people on the front line in a way that we've not done before. And for that to happen, folks have to feel safe at work. They have to feel safe taking some sort of well-managed risk, you know. And the start of that, I believe, sort of psychological safety spaces, you've got to believe that the people who run the organization believe the same thing. And I mean, I think we've successfully managed to do that. I doubt very much if many of our staff don't think we mean it. They may tell us we don't always get it right, which is, and we'll hold our hands up, but I think they think we mean it.
Yeah. I'm just going back to our question there that we asked at the beginning, and I was just looking at some of the responses and, you know, have you ever made a mistake and how did it make you feel? And, you know, some people trying to figure it out, why it happened, utter failure, shame, embarrassed, guilty, angry at myself, I felt bad. You know, it's as if, you know, this is something we have to do. There's a moral kind of reason to address the way that people feel, the emotional burden of the work that we do, and if we don't address that, then we're doing staff a great disfavor, I think.
So I add something here. There's a question by Claire Rowe in the chat, which is about how do you balance all of this, particularly in a highly litigious world. And I just want to describe a sort of moment when the scales fell away from my eyes, when this sort of linked the work we were doing with restorative just culture to one of those perfect care goals, the zero suicide one, you know, where it was really clear as we started to develop restorative just culture, we were in the events after a suicide in our care, we were starting to get the information out much more quickly, much more accurately. And of course, that was to bereave people. We were getting that information out. Historically, one of the big criticisms we often got when we talked to families was, but your story changes every 2 weeks. And because your story changes every 2 weeks, you're telling us lies. And actually, the truth of that, the pathology of that was staff disclosed in pockets of information. They didn't tell you everything at once because they didn't feel secure in telling you everything at once. But the net effect of that on bereaved people was, hang on a second, you never said the same thing twice. And for us now getting closer to be able to say that this is what really matters, I think we've seen litigations. I mean, we'd have to look hard at this, but I think we've seen litigations reduce. I think we've seen better relationships with bereaved people, because the process of early resolution is the thing that we keep going for. That's true dealing with staff, but it's true dealing with patients and potential litigious patients. So I think this is another example of how you get to that virtuous circle piece. And actually, my guess is we'll see a reduction in litigation as we go.
Great. And that, I suppose, chimes in with the open disclosure experience as well. That counterintuitively brings an actual reduction in litigation and improvement of everybody's experience. A couple more questions. Sorry, Amanda.
It just goes to that feeling the duty of candor as a clinician, that you feel able to give the full story, not 50% of the story, but the full story of what's occurred. And that's where the benefit of the learning comes in and then can help in the preventional space. And we had lots of conversations at board as, why are we hearing the same things time and time again at board? Why is there an action plan that kind of said the things that happened last time? It's repeated. It's almost as if, it's kind of in the old terms, tip X out with a new name and similar actions. So if you're experiencing the similar things happening on a repeated basis, it would demonstrate that the learning isn't occurring. And I would often think that's because people don't feel able to give the fullest of responses when you ask them to reflect on an incident, because they feel the who was there. You're not showing that you're looking at contributory factors like staffing, environment, training, development, all those things that can contribute to an incident occurring.
Great. Just a question there from Samantha Hughes. Was there a key change implemented in your organization that really set you in the right direction? If you were to pick one or two, maybe early actions again.
I think the first thing we did, which was what staff side asked us to do, was they knew we were serious if we reduce the amount of staff we suspended and we reduce the formal investigations. And that's what we set out to do. So when there was an incident or an event, rather than rushing into, what's your terms of reference, we're going to investigate because that's happened, what did Amanda do? We took a step back. And that actually seen a major change in reduction in suspensions and reduction in disciplinary investigations, because previously we'd had an awful lot of investigations which had resulted in no case to answer, but we put people and teams through these very intense investigations, and the impact is really very profound. So whilst we show those graphs, we have to remember there's a person behind those graphs, and there's a team watching what you do to your staff member, and there's a family who are also watching as well.
I think another thing, John, is if I remember, Amanda, at the time we were beginning to work this through, we went through some staff tribunals.
Oh yeah.
Sort of overturned, in essence, some of the decisions, because I think it was really important that we demonstrated that we now have a different optic on this. And quite a number of things we saw actually were people who were being disciplined because the organization's policy had allowed them. I mean, somebody who had fallen asleep on night shift, and yet our policy said, I can't remember, something like no more than 2 months at a time on a night shift. This guy worked about 12 years on a night shift. So we've broken our own policy, but we're going to discipline him for breaking the policy. So the absurdity of it, I think, is important. And the last thing I'd say was a really simple thing that Amanda introduced was the idea of restorative just culture champions. And we pulled those people from every layer of the organization. And their job was to sit down and talk about it in a meaningful way and decode and demystify and just over a coffee with people. And that wasn't the executives talking about it. That was our HF, our FNA type people, our nurses, our doctors, whoever it was in the organization, was then starting to argue the case for this.
And that addresses, I think, one of the questions there from Peter, just, how did you engage people, throughout the organization? And I think you used the word earlier, co-production. I mean, in terms of, did you, not just engage, but kind of share, I suppose, the power of how these ideas were going to be kind of brought into the world with staff?
Staff side, but we also Joe and I met with an awful lot of staff who had been previously experienced, whether it was a patient safety issue, review, investigation, whether it was a HR one. We met with individuals and we listened to their experience despite our intent in the application of our processes and the impact that had. And we did that an awful lot. And actually, some of the people who helped co-produce it had been subject to those experiences. So if you think about where the those individuals are really not trusting or believing in what we say, we're prepared to come along and walk this journey with us, and we'll forever be in their debt, actually, as indeed staff side, in terms of being prepared to walk side by side and trial and test until we had some of our frameworks to give a little bit more rigor and discipline around how we enact it in practice.
Well, Joe and Amanda, it's been a real pleasure talking to you today. Thank you so much for giving up your time. I know you're so busy. Lovely comments there again. Great presentation. You know, people really kind of, I think, taking what you're saying on board and you know, valuing it. I think we're hoping, you know, that in December we're going to see you in Dublin, and we're in the process of arranging a Just Culture conference on the 6th of December, and I think people will hear more about that shortly. And so it'll be a real pleasure to welcome you to Dublin and maybe to go in a little bit more depth into, you know, some of the work. And I was particularly impressed with the level of detail on the practices, you know, that you obviously have spent a lot of time thinking about, and maybe that's something we get to explore in more detail the next time.
Good. Look forward to it.
Lovely. Well, hopefully see you in December then.
Thanks
Yeah,
so much.
super. Thank you very much.
Thank you.
Bye.
Bye-bye.
Bye-bye. Bye-bye. We're just going to pop the slide up there, folks, just to some Just Culture resources. There's a HSE Just Culture Guide and Assessment Framework. And again, Joe and Amanda made reference to the movie, Just Culture, the movie, and then from Sidney Dekker. And then finally, the Mersey e-learning packages from Mersey Care in Liverpool. Next slide there, please. Just to remind people, if you haven't already, you can use the QR code there to bring you to the Walk and Talk Improvement podcast, and we have several episodes up there now, and we'd really encourage people to listen to it. It's been a podcast done in partnership with our colleagues from Northern Ireland, and I think you'll find lots of really good ideas, lots of engagement across the system, and I'd certainly encourage people to check that one out. You can use the QR code to bring it to the Spotify. Next slide. Just want to make people aware, and again, if you've joined in for today's session, I think this may be a particular interest to you, just to highlight the open disclosure resources and the prospectus of education and learning program. These are the resources that the National Quality and Patient Safety Directorate educational resources that are available. Again, Stephen's put the QR code in there to bring you to the prospectus. There's a couple of modules specifically on open disclosure, about the principles of open disclosure in practice and about communicating. You can contact the open disclosure team then to discuss skills training and train the trainer. And then they have a monthly webinar. I think the next one will be in October, if people are interested in that. So there's lots and lots of resources, and use the QR code there to check out the prospectus. Next slide. Again, just to remind people, another QR code there for the QPS Ireland network map. So this is a map of all people who are interested in working in quality improvement to really let people know where you are and to connect with other people maybe in your area of specific interest or in your region. So the best way to find those people is to get yourself on the map. And again, the QR code or the web address there will take you to that. Next slide. And again, a reminder to join the Q community. Similarly, again, to hook up with people in Ireland who are interested in working in quality improvement. But you also, in the Q community, get to work and meet up with people across Northern Ireland and the whole of the UK. So again, you may find people in your special area of special interest, and you can join special interest groups, and there's lots of other programs, including research that Q supports. So best way to find out about all of that is to join up, and you can contact our colleague Caroline Nenanali. Her email is there. Next slide. And then finally, just a reminder of some upcoming events. We have a special QPS talk time coming from the IADNM conference on Thursday, the 6th of October. So that's next week. And that is with Kathy MacDonald, who some of you may have met or heard speak before. She's a hostage and crisis negotiator and a wonderful teacher on communication practices. So I think that'll be a really, really excellent session for those who can join it. And then on the following Tuesday, on the October 11th, which is our regular QPS talk time slot, we have we're coming to you live from the National Patient Safety Office conference in Dublin Castle. And what we're going to do is get to speak with some of the keynote speakers from the day and bring you some of the highlights and some thoughts from the conference. So I hope you get to join us for those, and we'll see you at those events over the coming weeks. And then last slide. So just, yeah, at the end of the session today, you'll get a questionnaire. Please fill it out. A couple of key questions, how you found the session and your ideas for future sessions. Please let us know what you think and get back to us. And we will take your ideas on board. And you can include, you can email Stephen if you want to be included in our mailing list to receive invitations. And that's really it from us today. So thank you very much. Thank you to Maureen and Shima and Stephen, all in the background, and for Juanita as well in her help making sure that today's session went smoothly. And we look forward to seeing you in a couple of weeks' time or at the IADNM event next week. Bye-bye.